Welcome to this experience sharing program on managing PPH, case studies from labor room. This program is brought to you by Hetero Healthcare, an innovative pharmaceutical company. For Hetero Healthcare, the journey began in 1993. We have got 25 plus years of excellence and 36 state-of-art manufacturing facilities, 300 plus products in portfolio and presence in 126 plus countries, 21,000 employees globally, and Hetero Healthcare is the largest closely held pharmaceutical company in India. Hetero Healthcare is among the largest manufacturers of ARV, APIs, and FDFs in the world and has Asia's largest API manufacturing at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patients, because of which in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's program, Experience Sharing Program on Managing PPH, we have got Honorable Speaker, Dr. Sujaya Hiregoudar with us. Welcome, Madam. Welcome to this program. Dr. Sujaya Hiregoudar is MBBS DGO Fellow in Reproductive Medicine. Madam is Consultant Fertility Specialty, Obstetrician and Gynecologist, and Medical Director at Hiregoudar Hospital, Hubli. Madam is currently keen on pursuing exclusively on practicing reproductive medicine and IVF specialty. Special interests include laparoscopy, hysteroscopy, IVF, and reproductive medicine, and to update with all recent ongoing advances in their specialties. With this brief introduction, I hand over the session to Dr. Hiregoudar. Over to you, Madam.
Yeah. Good evening, everybody.
Good evening.
And I would like to thank everybody for giving me this opportunity to speak a few words and my knowledge regarding the postpartum hemorrhage and the use of carbetocin in postpartum hemorrhage. Yeah. What is postpartum hemorrhage? PPH is a loss of around 500 ml of blood following a vaginal delivery and around 1000 ml following a C-section. PPH is more common in women who are not at risk, but it's a leading cause of maternal mortality in low-income countries, that is the developing countries, and it almost leads to 1/4 of the maternal deaths globally, all over the world. Yeah. Next slide. Mostly the causes of PPH is unknown, but it's fortunate yet common. The maternal mortality, it's almost accounting to 35% of the maternal deaths. And in developing countries, it is almost 240 per 1 lakh live births compared to 16 in the developed countries. So the maternal mortality ratio is high in the developing countries compared to that of the developed countries. The global PPH incidence is 14 million women suffer from PPH. The incidence is almost of 2 to 4% after a vaginal delivery and 6% after the C-section. In India, it accounts almost to 38% of the maternal deaths are due to the PPH. 25.7% of the global deaths take place in India, and 2/3 of these attribute to PPH. India has unexpectedly high maternal mortality and maternal death rates of almost 540 per every 1 lakh live births. What are the etiology? What are the causes of this PPH? It could, like we call it as 4 T's, like tone, thrombin, trauma, and tissue. When there is lack of the tone in the uterus, that is uterine atony, inability of the uterus to contract, which may lead to the continuous bleeding. And because of the lack of thrombin, that is failure in clotting, will lead to postpartum hemorrhage. Because of the trauma, like injury during the birth and rupture of the uterus, uterine inversion, and perineal lacerations lead to postpartum hemorrhage. And even when there is a retention of the placenta, placental bits, and abnormal placentation also can lead to postpartum hemorrhage. What are the clinical findings in PPH? The most common is the abdominal tenderness, and at times there could be circulatory collapse. There will be increasing abdominal girth, loss of uterine contractions, maternal tachycardia, vaginal bleeding, hypotension. So depending upon this, we have graded the PPH into different types. Mild, which is almost around compensatory, is almost 500 to 1000 ml. contributing to 10 to 15% of the blood loss, and there are no blood pressure changes. And the signs and symptoms, usually there is palpitations, dizziness, and tachycardia. In mild PPH, it is a loss of almost 1000 to 1500 ml, which is almost equivalent to 15 to 25% of the blood loss. The slight fall in the BP of almost 80 to 100 millimeter of mercury, and the patient will present with weakness, sweating, and tachycardia. In moderate, it is around 15 to 2000 ml of blood loss, accounting to 25 to 35 percentage, and there is marked fall of the BP, almost 70 to 80 of mercury, and restlessness, pallor, and oliguria is also seen. In severe, it is almost 2 to 3 liters, accounting to 35 to 45% of blood loss, and there is profound fall in the BP. Almost the BP goes up to 50 to 70 millimeter of mercury, and there is collapse and air hunger and anuria seen in the patients. Next slide. How to approach towards the postpartum hemorrhage. You have to first find out what is the reason for this postpartum hemorrhage. In poor uterine tone, you have to just palpate the abdomen to see for whether the uterus has contracted or it is soft or relaxed. And uterine fundus may be felt above the umbilicus if uterine cavity is filled with blood and blood clots. Investigations, we have to send a complete hematocrit, CBC, coagulation profile, urea, and electrolytes. And if the patient is not responsive to fluid and blood replacement, abdominal ultrasound to exclude uterine rupture or intraperitoneal bleeding. How to manage this? Uterotonic agents are usually given, like oxytocin, prostaglandins, and ergot alkaloids. Uterine balloon tamponade can also be done in extensive cases. Then the thing is that we have to find out if there are any tears or trauma. Clinical findings, usually there is profound bleeding, but the uterus is well contracted. Uterine rupture, extension of the uterine angles during C-section, tears during C-section, extragenital causes such as subcapsular live rupture or rupture of ovarian or splenic vessels. The investigations sent are usually inspection during C-section by exteriorization of the uterus. Ultrasound may also help to know whether there is any rupture. Management is to repair or suture the extended angles during LSCS and identify the genital tract trauma. Pelvic arterial embolization, either we do a uterine artery ligation or internal iliac ligation. When there is retained tissue, we have to identify by bimanual examination. Investigations are, we have to examine under anesthesia for any retained bits of placenta. Management is manual removal of the placenta or retained bits of conception under regional or general anesthesia. For coagulopathies, if there is continuous bleeding, though the uterus is contracted, we have to send for the renal profile, the electrolytes, the full blood count, and the coagulation profile. Management is immediate replacement of the blood components, and in surgical, only in case of trauma or atonic PPH, we use for the surgical managements. Attempts should be made to identify the cause in women who are bleeding in parallel with resuscitation. Both should go hand in hand. The next slide. What is the rationale for the development of carbetocin in new heat stable formulation? Carbetocin is available in room temperature stable formulation and convenient while presentation. Oxytocin and ergot alkaloids should be kept in a refrigerator to avoid degradation. Heat stable formulation of oxytocin is currently not available. Previous formulation of carbetocin should be stored between 2 to 8 degrees Celsius. Resource poor countries do not always have cold chain transport and strong storage capabilities. This carbetocin, the newly developed molecule, it's stable at the room temperature, has a shelf life of 24 months at 30 degrees Celsius and 75% humidity, avoids need for cold chain storage and logistics, and is provided in a vial. What are the use of uterotonic agents? At the crowning of the baby's head, at the delivery of the anterior shoulder, and at the end of the second stage of labor, following the delivery of the placenta, usually we use uterotonics. Basically, we use this to prevent PPH and active management of third stage of labor. Therapeutic uses for the management of PPH. Usually, the molecules which are used as uterotonics are oxytocin, carbetocin, ergometrin, synthometrin, which is a combination of ergometrin and oxytocin, misoprostol, and carboprostol. So, in few cases. Next slide. Carbetocin. This is a molecule which is a next generation drug for PPH management. Carbetocin was created by making several modifications to the oxytocin structure. Basically, it has prolonged half-life and reduced enzymatic degradation. This is a synthetic long-acting analog of oxytocin with a therapeutic indication used in PPH due to uterine autonomy. One vial contains 100 microgram of carbetocin in 1 ml solution for injection. The clinical evidence for carbetocin versus oxytocin. The characteristics which compare oxytocin and heat-stable carbetocin. Oxytocin is a synthetic cyclic peptide form of naturally occurring posterior pituitary hormone, binds to oxytocin receptors in the uterine myometrium, stimulating contraction of this uterine smooth muscle by increasing the sodium permeability of uterine myofibrils. Heat-stable carbetocin is a long-acting synthetic analog of oxytocin with agonist properties. Binds to oxytocin receptors in the uterine smooth muscle, resulting in rhythmic contractions, increasing frequency of existing contractions, and increased uterine tone. Oxytocin, when given IV, has a peak concentration after 30 minutes, while that of carbetocin it starts acting within 2 minutes and lasting for almost 6 minutes and followed by rhythmic contractions for almost 60 minutes. IM oxytocin has a slower onset, taking around 3 to 7 minutes, but produces a longer lasting clinical effect up to 60 minutes. And IM carbetocin has sustained uterine contractions lasting for about 11 minutes and rhythmic contractions for 120 minutes. The half-life of oxytocin is only 1 to 6 minutes, while the half-life of heat-stable carbetocin is 40 minutes. Regarding the storage and transport, oxytocin is very sensitive to temperature. So it requires a perfect cold chain of 2 to 8 degrees Celsius continuously, while that of carbetocin can be stored up to 30 degrees Celsius with no cold storage requirement. And basically, oxytocin is also used in induction of labor, augmentation of labor, and prevention of PPH, which we cannot use carbetocin in induction of labor or augmentation of labor, but definitely it can be used in prevention of PPH. In the treatment of PPH, oxytocin is a better drug compared to that of the carbetocin. Next. So there was a trial which WHO has conducted a champion trial, which means carbetocin hemorrhage prevention trial, which is the largest clinical trial in the prevention of PPH. This was conducted by the WHO Department of Reproductive Health and Research. The study designed non-inferiority at double randomized clinical trial to compare the effectiveness and safety of the investigational heat-stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. 30,000 women across 10 countries were included, including India. Primary outcomes: the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents. The proportion of women with blood loss of at least 1000 ml of women. So, carbetocin, which is the newly invented drug, is non-inferior to oxytocin. The WHO champion trial, it compares the efficacy between carbetocin and oxytocin. When there's a blood loss of more than 500 ml or the additional use of additional uterotonic, the efficacy of carbetocin is 14.5% compared to oxytocin, which is 14.4. And the blood loss, when if it is more than 1000 ml, the efficacy of carbetocin is 1.51%, whereas that of oxytocin is 1.45%. And the thing is that the frequency of blood loss of at least 500 ml or the use of additional uterotonics agents with carbetocin was proven to be non-inferior versus oxytocin. The use of additional uterotonic agents, interventions to stop bleeding, and adverse effects did not differ significantly between the two groups. So the conclusion was carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. The Cochrane reviews regarding the prevention of PPH. In this Cochrane review, data from 11 studies involving 2,635 women. The author concluded that for women who undergo a C-section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to that of oxytocin. Also, carbetocin is associated with less blood loss compared to that of syntrophin in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer side effects. What are the guidelines and recommendations for the use of carbetocin in preventing the PPH? There are different bodies which recommend the use of carbetocin. WHO 2018 tells the only use of the carbetocin, oxytocin, and misoprostol, methyl ergometrin, oxytocin, and ergometrin fixed dose combination. And SOGC Canada tells carbetocin 100 microgram of IV bolus is better for PPH prophylaxis. Ranzog, New Zealand tells active management of third stage of labor, prophylactic uterotonics. FIGO has recommended carbetocin, one of the recommendations for the PPH management. Germany, Austria, and Swiss body also have recommended carbetocin of 100 microgram slow IV. And FCOG France has recommended carbetocin on proving non-inferiority to oxytocin achieved by Champion trial in 2015. Next slide. Regarding my experience with carbetocin is basically compared to that of oxytocin, it is more potent in preventing the PPH, and the use of additional uterotonic agents is less compared to oxytocin.
Madam, since how long you have been using this drug, carbetocin?
Uh, Almost say 1.5 to 2 years we have been using.
And you do quite many IVF cases also, no?
Yes, yes, yes,
Even in IVF, there is sometimes a requirement, maybe in twins or maybe otherwise, there is a
yes,
requirement of carbetocin, no?
yes,
I mean, you will, during the delivery, prophylactically, you will use carbetocin.
yes, definitely.
Yes.
Instead of oxytocin, now we have switched over to carbetocin only.
As a first line.
Yes, as a first line.
These are some of the questions which have come.
Yes.
So generally, it is said that incidence of PPH is more in India, although the incidence of PPH has come down over a period of time, but still it is more in India as compared to other
Yeah,
places.
basically the incidence of PPH is more in India because it's because of the limited access of
Ah,
the patients to the emergency obstetric care. Even the birth attendants are not trained well in rural areas where the patients
absolutely.
cannot reach the tertiary care centers. Even anemia, which is very rampant in
Yes, yes, I
India,
was coming to that. Yes.
anemia leads to PPH, and even malnutrition among the pregnant women. Most of the like all the organizations in India have been focusing on the nutrition in pregnant women, but still this is lacking. Somewhere we are lacking in this. So
Yes.
this all these reasons will definitely lead to PPH.
Besides anemia, I suppose even protein deficiency or even
Yes,
calcium deficiency is very common
yes,
in our country.
yes, yes, yes,
You know, when
yes.
I was working in the interiors of Maharashtra, I was lucky to get a hemoglobin of 5%. I mean, it was
So
that, of course, it's very long, but
yeah.
then what are the patient profiles where a doctor can anticipate a PPH?
In
Although you
prolonged
can expect in
labor.
any patient, yes.
Yeah, in prolonged labor where the labor goes more than 12 hours, and even in precipitate labor where the labor occurs in less than 30 minutes or 1 hour, also we can expect PPH. And in uterine overdistension like twins, big babies, polyhydramnios, and when there are infections like chorioamnitis and high parity,
Okay.
so previous history of PPH, all these cases definitely we can expect PPH. And abnormal placentations like placenta
Yes,
previa,
yes, yes.
placenta accreta, abruption, and retained products of placenta also, we expect usually PPH to be there. And when there is an emergency C-section also, or it's a difficult C-section also, there can be tear in the and extended uterine angles for a big baby, and for instrumental deliveries like vacuum, forceps, and uterine inversions. And even at times we have seen
Yeah.
in IVF cases where where we use ART techniques because of the endometriosis and adhesions and everything. When we try to exteriorize the uterus, there is a lot of atony which is seen.
Okay. Uh,
This I've seen with most of the cases. So we will be very cautious in exteriorizing the uterus, especially when it's an IVF case. And
Correct, correct. Madam, I mean, just for my information, is the risk of PPH more with vaginal deliveries or more with cesarean section, something like that, or it's not nothing to do with it, not related?
usually it's not related, but most of the times I feel ki vaginal deliveries are more at
More
risk because
likely,
of the
yeah,
lacerations and everything, and
yeah,
cervical tears and all.
correct. And the things which we will not be knowing the what is happening actually inside.
Yes,
Yeah,
yes. It's not revealed basically.
exactly.
Yeah,
Yes, we have discussed this. I don't want to take your
yeah,
time again.
yeah.
And again, we said that besides anemia, calcium deficiency or protein
Yes,
deficiency could also be contributing.
yes.
And beside, of course, you said you use oxytocin. Anything else you would use for prophylaxis?
Usually we use oxytocin and misoprostol 600 micrograms also. We insert it, we don't give it orally. We usually give it,
Rectally.
insert it rectally.
Yeah.
So at times, even after the closure, if we feel sometimes the uterus is relaxed, then we give even, we put two tablets also, 1200
Okay.
micrograms.
Yeah, yeah, yeah. And madam, at what stage you give carbetocin for prophylaxis?
Immediately after
Immediately
the
after
delivery
delivery.
of the baby.
Immediately after delivery.
Immediately after the delivery of the baby. The anesthetist will be ready with the drug.
Yeah, in big hospitals, that's one advantage. IV lines are already there.
Yes, yes,
In all patients, you have already answered this.
yes.
You prefer IV route or IM route, madam, generally?
See, usually we prefer IV route only because IV has got immediate action of almost, it
Yes.
starts acting within 2 minutes.
Yes, correct, correct.
Yeah, and the bioavailability of the drug is also almost 100% with IV.
Yes, yes, yes.
While compared to that of IM, there is a slower peak, almost around, I can say, 20 to 30 minutes.
Okay,
And the
that is good.
bioavailability is also around 80% bioavailability.
Oh, so it takes longer. But
Yes,
then
it's
the one
taken.
advantage with IM could be a little longer duration of effect.
No, the longer duration, both are almost of the same
Almost the
duration
same.
because
Yeah.
because the half life of the drug remains
It
the same.
remains the same. Correct.
Half life of the drug is the same, whichever route you are going to give.
Correct. So IV definitely has an advantage because it
IV has
also
an added
faster.
advantage.
And in PPF, I mean, every second would matter and
Yes,
faster
yes,
out to
yes,
behave.
yes. The 40 minutes half life is common to both
Both
IM or IV route.
route.
Yeah.
Now, how fast you already said, but in IV route, it starts acting immediately within 2 minutes
Yes, within 2 minutes. Within two
and it
minutes.
lasts for about,
It lasts for almost about say 60 minutes.
oh, that's sufficient enough, I
Yeah,
suppose.
yeah, yeah, yeah.
Any experience of using Carbetocin in RH negative mothers?
Not really much, but definitely the need for additional uterotonics has definitely come down.
Come down. Yeah.
Yeah. And because it's more heat stable,
Yes.
longer acting compared to that of oxytocin, so it's a better drug in using for high risk cases and Rh negative cases and all.
I suppose heat stable is the greatest advantage in our
Yes,
country where there
yes,
is power
yes,
outage
yes,
everywhere.
yes, yes.
Yes. And even after using Carbetocin, there could be a PPH, but how frequently you would see a PPH after using Carbetocin?
I have not seen, but according to the textbooks and all,
Yes.
according to the Google, what it says is it's around 3.3 percentage.
Okay.
This I have not seen
And
personally, but this is what the Google tells.
PPH is a top is a
3.3%.
yeah, PPH is a wonderful topic to discuss, but we always
Yes,
pray that no one should get a PPH.
yes,
Please, please,
yes,
please.
yes, 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 yes.
If PPH occurs in spite of using Carbetocin for prophylaxis, do you feel in that case there could be a reduction in the amount of blood lost?
Yeah, definitely by trying other uterotonics like oxytocin, misoprostol, and methylergometrin, synthometrin, definitely, and tranexamic acid, all this we can definitely prevent PPH.
These days, madam, do you use tranexamic acid straight away as prophylactically or only during treatment?
Only during the treatment. We
Only
don't
during
use
treatment,
prophylactically.
prophylactic.
Unless and until we, like the patient was already
Yeah, yeah,
on
yeah.
heparin 40 mg all through, suddenly we had to take her up for LSCS. So only in such cases we give prophylactical, or else we don't give.
Another risk factor could be aspirin. There could be many patients. I
Yeah,
mean, there, yeah,
aspirin also, yeah. But usually 32 weeks we taper the dose from 150 to 75 mg.
correct.
Yeah,
And what are the advantage? Of course, we did discuss this, but basic
yeah.
advantage, I suppose,
It's a heat stable drug. It's longer duration of action, and it's a single dose of injection which has to be taken. And there's no need of constant IV infusion, which unlike that of oxytocin,
oxytocin.
and it has better hemodynamic stability compared to that of oxytocin.
Have you seen anytime seen ADH related adverse effects with oxytocin?
Not much.
Even I
Not,
have not seen,
not.
but it's rare. They
Yeah,
document
yeah,
it. Yeah.
yeah, yeah, yeah.
How well is Carbetocin tolerated in your experience?
It's tolerated well.
Well,
Usually they say there's headache, nausea, vomiting, and
I
all, but I have not seen anything of that sort.
mean, looking at the
Even,
what it prevents, this is
yeah,
nothing. I will
yeah,
say.
yeah,
Yeah.
definitely.
What is the benefit? Suppose we say that Carbetocin should be used as a first line. What would be the benefit to the patient
The thing is that it starts acting immediately.
immediately?
The fastest action is the more important and prevents blood loss. So more heat stable drug and everything. So that's the reason why it's a better drug compared to that of oxytocin.
Ideally, doctors should use it as a first line in every patient and for every delivery.
Yes, yes,
Yeah.
yes.
And to conclude, madam, your overall experience, sharing your experience and take home message for the audience.
Carbetocin is, I think we have to start using it more rampantly compared to that of oxytocin for prevention of PPH because it's more heat stable, better acting, long acting drug, and good with good bioavailability and longer half life compared to that of oxytocin. So carbetocin is a better drug. So I recommend all the obstetricians and gynecologists to start using carbetocin as first line of drug for PPH for prevention of PPH rather than oxytocin. I think it should in the uterotonics the first name should be carbetocin instead of oxytocin.
Madam, thank you so much for sharing your experience.
Thank you.
I'm
Thank you.
sure the audience has benefited out of it,
Yeah.
especially, I mean, in IVF, when you use it now, that confidence our doctors get. And one
Yeah.
interesting thing you said, that besides anemia, there could be other deficiencies which could also make patients prone. Thanks
Yeah.
so much. Thanks for madam for
Thank you.
taking time and sharing your experience.
Yeah.
Thanks all the doctors who took time and attended this webinar. Thank you, IT team, sales and marketing team of ITRO. Thanks, Sanjana. Thanks, Tanvi, for attending for this webinar. Thank you so much, madam. Wish you a pleasant evening. You can sign off, madam.
Thank you.
Thank you.
Thank you, sir.
Thanks, Sanjana.